Welcome to Living Vividly, the podcast where health, wellness, and curiosity collide. I'm Jackie, the founder of Vivid Health and Wellness, your guide on this journey to living your happiest and healthiest life.
My co-host Daphne, the unconventional dietitian, is always ready to shake things up and bring a fresh perspective to your wellness journey. And we can't forget Dustin, our producer, who keeps everything running smoothly behind the scenes. Together, we'll chat with health and wellness experts along with everyday people who have inspiring stories and practical insights to share. If you're ready to nourish your body, move better, and discover simple ways to thrive, you're in the right place. And hey, if you enjoyed today's conversation, don't forget to leave us a comment sharing your thoughts, and subscribe so you never miss an episode.
Welcome to the podcast, our second Dr. Thompson.
Yeah.
Hopefully, I can live up to the name for the first one.
Our first Dr. Thompson was your wife, also a fellow PT. So we're really excited to get to know you and kind of how you're different.
Well, yeah. Well, first off, I'm happy to be here. I'm excited to be here. Anytime that I get to nerd out about being a PT in the physical therapy world, I can talk to the wall about being a physical therapist and kind of like the passion around it. But it's nice to speak with people who come back and speak back to me and not just talking to the wall. So I am, as mentioned, Dr. Patrick. I have been a physical therapist now for 13 or 14 years. Went to LSU over in New Orleans in a life before physical therapy. I'm from Houma, born and raised in Houma. Went to undergrad at Nichols, where I played baseball there, but also graduated in athletic training. So kind of a similar profession, athletic training and physical therapy. Pretty parallel in the sense of like orthopedic rehab, orthopedic injuries. Maybe clientele can be a smidge different. The professions come a long way. When people say they don't know what what an athletic trainer does, I always say they're the guys and gals that run onto the field, do those quick assessments, and then get the athlete safely off the field and then do all the magic behind the scenes. So was an athletic trainer first, so kind of got my feet wet in that world. And then before I could actually formally practice as a certified athletic trainer, if you want to use that word, I went to PT school. So moved to New Orleans right away, went to physical therapy school, and been addicted, been hooked ever since. Came out in 2012.
So it sounds like this has always been a passion of understanding like how the body works, how I think in physical therapy, in my mind, you have to understand like the mechanics and angles and physics and all those things, but that sounds like it's always been kind of deep rooted inside of you.
One track minded, or especially in the world of orthopedic physical therapy, there's a lot of subsets of physical therapy. You get deep into the weeds with physiology when it goes like neuro-based physical therapy with MS, TBI, etc. But in orthopedic based physical therapy, it is very lever heavy, biomechanics heavy, pulley system heavy. I kind of explain it to my patients as our body's just an intricate system of levers and pulleys that lever A moves and makes lever B do this, and then if something's not moving efficiently enough, where are we missing out a little bit?
It's kind of the engineering of the body.
It is. It's absolutely. And whenever you can kind of anatomy based kind of see the body as it moves, then it makes it easier to, I don't know, use the word repair, but a mechanic needs to know how the intricate details of the engine to be able to fix the engine. So, but yes, orthopedic. I've been orthopedic minded ever since the beginning. It is kind of a one track road for me. That's all I wanted to do. You go through physical therapy school. They do a great job in school making you become a generalist. They want you to see everything. They want to make sure they expose you to all the different avenues of physical therapy. I call it to check the boxes to make sure that you're going on the path that you want to go down. But it was evident for me from the start that I always gravitated back to orthopedics. I always gravitated back to injury, rehab, and getting people back moving better, more confidently than ever.
Is that like a subspecialty? Do you have to get further training for?
Such a great question. So a lot of times people think about physical therapy, and I love it, but almost like the public perception, if you want to use that word, of physical therapy is orthopedics. You think about a physical therapist, you think about the dreaded yellow TheraBand, kind of shoulder exercises, mini squats, hamstring stretches, all those things that, with all respect, all the PTs that do a lot of those exercises, it's kind of the minimum or the bare minimum of what it is. So when you come out of physical therapy school, the way that I explain it to people is kind of like when you come out of med school, you're an MD, but then the medical system or the medical school system, they advocate and they make you go through a residency. They go through a fellowship to become further specialized. So whether it's you at the residency of cardiology, oncology, all these different avenues, then you go through and become a specialist in a certain field because, I mean, you would never expect one MD to know the details of every single avenue. So physical therapy, I personally think we're a little bit behind on that, and that whenever you come out of PT school, you're a physical therapist. And quite honestly, you're a physical therapist. You know, it's up to, at that point, it's up to the physical therapist to take it upon themselves or herself to specialize if they choose to specialize. So you come out of PT school and typically you kind of go to where you feel like you're going to fit in a little bit. And I call it, you go back to school, but this time you kind of learn from the school of hard knocks. You kind of get hopefully some good mentorship from your first job, show you the ropes, show the difference of textbook versus real life patients, the whole thing. But to answer your question, orthopedics, it can absolutely be a specialty and it should be a specialty. And with the route that I took was that I gave myself a 5-year window to hopefully learn from any mentors I could get my hands on or learn from different jobs, on the job experience, the whole thing. And then through the American Board of Physical Therapy Specialties, you can become a board certified specialist in a variety of topics, whether it's women's health, sports certified specialist, orthopedic certified specialist, geriatric, pediatric. There's a lot of different avenues that you can go. So I graduated in 2012. I think in 2016, I shouldn't quote myself, is where I applied for and took the OCS testing and got board certified in orthopedics, which just kind of a little bit separates. I don't want to say it's not a better or worse thing. It's more of a separation of this is what I do. If you want to have someone come or address orthopedic concerns, I'm your guy. Let's chat about it. If you're struggling with something more neuro heavy, again, traumatic brain injury, MS, Guillain-Barré, all those other symptoms that take, in my opinion, a lot of brain power and a lot of specialty, maybe we should funnel you into that physical therapist that's going to specialize and have spent the time to become specialized in that topic.
When you talk about orthopedics, like define orthopedics in my mind is bone, something bone related, but tell me what orthopedics means if you don't know.
Great question. Orthopedics, we kind of take it for granted that like everyone knows what orthopedics means. So yes, if you break it down, it's bones, muscles, tendons, ligaments, ortho, movement based. So whenever I say a physical therapist is an orthopedic specialist, think about muscle strains, ligament sprains, chronic injury, low back, gym injuries. Just like you go to an orthopedic surgeon for, if you possibly needed to go have surgery on a rotator cuff or a meniscus injury. So that's going to be the world of orthopedics. Bone, muscle, tendon, ligament, disc, joint related issues, whether it's arthritic changes, things like that. So again, still kind of painting it pretty broadly there, but that's the world where orthopedics, you can further specialize, of course, but that's the world where orthopedics lives.
And what part of that do you love the most?
Oh,
is there a particular joint that you love the most or
working
with?
I think if you'd asked me that question 10, 12 years ago, I might have answered it the best way I knew how. And I might have said something along the lines of I was really interested in shoulders at the time. I played baseball in college. I know I mentioned that, but I was very intimately aware of like shoulder injury, shoulder pain. A lot of my teammates, a lot of my friends. So I took an interest in baseball injuries, and that was heavy in shoulders. With that being said, now when I hear that question and I think about what joint I like to treat the most, I don't think of it, a person as a joint. Your shoulder, your knee, your low back, your hip, you're this. Mm-hmm. I look at that person as you're an intricate system of how every joint affects each other. So I view you as a whole person, as a unique individual, where my favorite thing to treat is you, the person. And I want to know on day one, what can you not do right now? And then we go down that rabbit hole of peeling the layers back of the onion of how you have back pain. Sure. What does that limit you from doing? Well, I can't stand up out of a chair as well. Okay, well, what does that limit you from doing? Well, I can't pick up my kiddos or my grandkiddos. What does that limit you from doing? So I think my favorite thing to treat is movement, and then I call it SPD. I want your smiles per day to go up because you're not thinking about these seemingly nagging injuries or seemingly low-level injuries that have large ripple effects in our life where we're not happy anymore. We're not spending time with our family. We don't have confidence in movement. We don't have the freedom to pick up and go on a road trip because we're afraid that our knees are going to start hurting because it bothers us when we sit. So I used to be a little bit more surface level 10, 12 before I got deep into the weeds of this. But now I look at it as my favorite thing to treat is a person in front of me that wants to get better and to give them the confidence to move around. And again, to increase SPD, smiles per day. It sounds silly, but it's just, there's something special. There's a feeling that I get whenever someone comes in on their first follow-up session. I call it my favorite word. They say, actually, I feel better. and it's really because I feel like at that point, I know that they didn't expect to feel better, or they didn't know what to expect.
Yeah.
And it's actually, I feel better, or actually, you know what? I slept through the night last night. I didn't even wake up. I wasn't hurting when I woke up, or I haven't thought about my pain in 3 or 4 days, or a week, or whatever the case is. I think that's, I don't want to say like that's the endorphin hit that I look for, but that's why I try to do what I do. It's not to make someone's knee feel better. It's to give that person the freedom to do whatever they want to do and not think about their knee. Let me think about your knee.
Yeah. So it sounds like you're treating quality of life.
There you go.
You're treating quality of life versus treating the individual joint that is hurting, that, that they may have gotten a script to go to PT for, the shoulder, the knee, the back, whatever. That's usually what you're going to PT for, but you're looking at it as we need to improve all of quality of life.
Sure, because a lot of times, even with that, let's take the ankle, for example. If someone comes in and they have a script, or they call them and they say, can I come to see you for ankle pain? Or my ankle bothers me, it's been bothering me for 2 weeks, I need to fix the ankle. We live in the world, and this is probably extends well beyond healthcare, but we live in a world of like Band-Aids, quick fixes, instant gratification, all that. And if you come in and we get hyper focused on a body part, in this example, the ankle, and you just want to be treated for your ankle, I can almost guarantee, which I rarely use that word, that I can make any body part feel better quickly, based on whatever quick fix tool we need to use that week, whether it's needling, cupping, mobilizations, all these things that we do, all the little features or the PT tools. But the reality of that situation is that you're still a victim to the ankle pain. And if we make it feel better and you don't then zoom out and treat the whole person, the ankle pain is likely to come right back, because it's not about ankle pain to me. It's about, why are you having ankle pain? And there's usually a driver to everything, every reason, especially when it's recurrent pain. Recurrent pain being, of course, you have, let's switch from ankle pain. So I have
one. I have what I call tennis elbow. Okay. So Alex described the pain. It's I'm left-handed, so it's on my left arm, not at the elbow, but in the front part of the arm.
Nailed it.
Right here.
Technical term.
And it has gotten better. So it started actually last September is whenever it started. I couldn't play tennis for a while. It started from me playing tennis. I couldn't play for a while. I did some rehabby type things. It got better, and so I can play now, but it still hurts. I can still feel it. So if you want to use that as a point of reference for like big picture, it's not keeping me from doing anything, but it is still a pain that I feel frequently.
Sure. Okay. As you can imagine, there's still like a litutny of like additional things that we could chat about, all the way. There's a lot of awesome research and a lot of interesting studies on this, like thoracic spine mobility and mobilizations for tennis elbow, and 36% pain pressure threshold is drop immediately just from working through the mid back. So if I were to just like zoom in on your tennis elbow, which by the way, they can call that pickleball elbow now.
Yeah.
And I've even heard Stanley Cup elbow.
Okay.
The sudden increase of Stanley Cup mugs being super heavy.
I feel like I get a good arm workout.
That's
this isn't
right.
Stanley, but it's still quite heavy.
Exactly right. So
mine actually is tennis elbow though.
Right. So if you were to come in for a tennis elbow, especially a tennis elbow that sounds like it's gotten better, but it hasn't quite gotten over the hump, then that just tells me off the jump that we're going the right direction, because you feel better. And that's obviously a great start, but something else is still going on. Why is it coming back? What are the joints up to? You've got a couple joints right here in the elbow. It's not just one joint. It's 2 or 3 right there that can be mobilized, that can be worked on. Then, as I've already mentioned, we need to zoom out, look at the neck, look at the mid-back. What is going on day to day? Even though it's tennis elbow, Maybe that's just a trigger that got you over the hump. Maybe, let's make this number up. You'll feel it at 80%. You know, maybe you were already at like a baseline 75%. So when you went out and played tennis, that's all it took was a jump over to get over the 80%. And we've got it controlled that we're living at that 75% where it's okay. I like to say, well, there's something that we're missing here that needs to drop even lower so that you don't even think about it anymore. Because you're obviously still thinking about it. It's still there. It's on your mind.
Yeah.
I like it when people come in and they say, I don't even remember which elbow that was. You know, it's so far in the past that you can't even remember if it's right versus left.
And I think I've kind of gotten to the point where like it's not stopping me from, I feel it, but it's not, there was a time whenever I couldn't pick up a coffee mug because I couldn't turn a door handle, a doorknob. And I'm not at that point. That's when I was like, okay, something's got to give. And I'm not there. So I'm not addressing it at all, but the pain is definitely still there. It's much lower level, but it's definitely still there. So it tells me that there's still something wrong in the body. Something is not flowing the way that it's supposed to.
Sure. And it's, you know, think of it as like, you know, your house. Like, you know, it's just like your faucet is dripping. It's not hurting anybody. It's fine. But like, there's going to come a time where you're tired of the dripping. You're tired of hearing about the toilet keeps running like this. You know, something's there. The toilet still functions, the whole thing, but something is still there that can be considered bothersome. So really it turns into that point. How long do you let it linger before it either A, becomes an issue again, which we don't want that to happen, or two, you just, everything else in your house, I mean, everything else in your life is going great. You're just tired of this. Let's go ahead and take care of the elbow. So the way that I feel about that, just because I am cut from the cloth of being a purist in the world of physical therapy, is that being proactive and addressing it before, you know, it becomes the coffee can test where you can't drink your coffee or the doorknob. Because then naturally it can feel harder to address that because we've let it linger a little bit too far. But so that's definitely how I don't like to just body part someone, I call it, where you're not just an elbow coming in. You're a whole person that has all these other components of your life that may be contributing factors to your elbow pain, things we don't even think about. Day one of an evaluation is my opportunity to listen to my patient thoroughly, give them the floor for as long as I need to so they feel heard, they feel like they've shared and potentially overshared everything they need to share with me so that I have all the information that I need. And then I will still probably ask significantly more questions to ferret some things out. And then you kind of tinkered into the world there of differential diagnosis, which physical therapists are experts at differential diagnosis. And that is it rib versus disc bulge or costovertebral joint dysfunction, or is it the thoracic spine, or which rib is it? All those things. So that's what day one's all about, is that we go through an algorithm, a systematic approach of sure, movements, you have to move, but also tests, measures, movement, questions. Sometimes if you listen to a patient, they take you right where you need to go. If you give people the time to explain their symptoms, when does it hurt? How does it hurt? And all these little nuanced answers, it's like a big overcharged Venn diagram that the more information you have, certain things overlap. And then after we get all that, then we go through, I call the test retest, like things that should hurt, things that shouldn't hurt, what hurts, what makes it feel better. I tell my patients a part of any evaluation is what feels better or what doesn't hurt. It's like people think they should hurt coming into physical therapy. It's like you take your car to a mechanic and suddenly it's not clicking anymore. It's like, it's okay if it's not hurting right now. That's perfectly fine. There's still movement patterns that we can discuss and work through. So after that very thorough evaluation, then from there is whenever we can build a program or build a plan or talk about what phase one is of getting out of pain, and then what phase two is to stay out of pain, and phase three to not have to worry about recurrent pain coming back, all that kind of in that world.
That's such a thorough approach.
Yeah.
If someone comes in, like if I came in and said, hey, I have a dislocated rib, can we fix it? Would you just trust them, or would you still go through the thorough approach?
Oh, thorough approach.
Okay. So even if they are like, no, it's this.
Sure. Yes. Thorough approach.
Still thorough.
And it's not, that's not rooted in the mentality of not trusting the patient, because I do believe in patient knows their body better than I will. I mean, I can have, alphabet soup behind a name, or a person can have alphabet soup behind their name. But at the end of the day, you know your body, and if you know what you need, that's potentially accurate. But I'm still going to go through the algorithm. The way that I approach an injury or chronic pain or recurrent pain, or I approach your report, is It's unique, and you're not just a low back. I'm not going to lump you or pattern you into a bucket of low back generic cookie cutter treatments, or even in this case, generic rib-based physical therapy. Even though you've told me it is your rib, I'm going to make sure that I didn't cut any corners. One, it keeps me honest. It keeps me make sure I don't miss any of the boxes I like to check. I think it's a high responsibility that we are a direct access provider in Louisiana, where you can come to us without going to your MD first. You don't have to have a referral to come to physical therapy. You don't have to have an x-ray before you start physical therapy. So the second that you start cutting corners, gosh forbid, or you start patterning, or you start, this is going to sound bad, trusting the patient of exactly what's going on, because maybe they're biased on what's going on in their own body, then there leaves the potential for missing things. And if they haven't been going, or they haven't been to a doc in their MD or their primary provider in years, this is the first time someone's even talked about all these complaints is a negative word, all these reports, then I need to make sure that I'm listening to everything and I do a thorough assessment, so that if there is a need to refer for an x-ray, or if there is a need, you might need to head off to your doc because you need to discuss this specifically. And all these red flags is kind of like the medical speak word, red flags, yellow flags. I take a big responsibility in identifying red flags on the front end. If you're going to come to me first, I need to make sure that I'm addressing everything first.
Well, also, I think sometimes you have to, for me personally as a provider, I ask a lot of questions so that I can wrap my brain around, like, it's just for me, a lot of times it's people like constipation would be an easy one, because it happens to a lot of people. It's not always for the same reason. So someone may come and tell me, like, I'm really constipated and this is one of the biggest challenges that I have, after, of course, they want to lose weight. That's always number one. But then number two is that I can't poop for 3 days at a time. Well, let's talk about the poop first, and then I'll ask a gazillion questions about it, because it's more than just constipation. It's that, like, what is the root cause of it? And so in your case, for you to be able to wrap your brain around what the problem is besides just being a rib, then you have to ask all the questions that you need to ask to be able to fully understand what is encompassing that rib injury.
Sure, absolutely. So 2 different routes on that. One, some of the questions I ask, my patients look at me like, why are you asking that? Like, why is it relevant? And I kind of tongue in cheek or like laugh and I say, well, sometimes questions are like CYA questions, like cover your butt questions. Like, I kind of know what the answer is, but I need to hear you say what's going on, so I can kind of eliminate some things.
Do you ask them about their poop?
Sometimes.
Yeah.
If it's appropriate, in that, if you came in maybe with like a jam finger, I'm probably not necessarily. But if there's a reason to ask, I try not to waste my questions on things I don't need to ask about. And fortunately for me, I've got Dr. Melissa in the other room. Yeah. So if there is a constipation issue, I can always refer to my pelvic therapist.
Oh, y'all are in the same building?
Oh, yeah.
Oh, that's cool.
Oh, yeah. But yeah, so wrapping my head around the entire situation that presents in front of me and kind of tunnel visioning in on a patient is good in its own sake, but also you need to zoom out and look at the whole person too.
Right.
And then maybe zoom in, zoom out, and then zoom back in on your target.
Yeah.
But there needs to be like a dance or a rhythm to that when you're treating your patients, so that one, the patient feels comfortable, the patient knows that you're asking all the questions. There's no better compliment than I get from a patient that whenever they finish up an evaluation with me, especially a patient that maybe has gone through the ringer of traditional insurance-based physical therapy or chiropractic care, massage therapy, all the other world of injury rehab providers. And they say, wow, that was totally different evaluation I've ever had. That was the most thorough evaluation I've ever had in my life.
Nobody's ever asked me that question before.
No one's ever talked about this. No, I didn't expect that. You found things I didn't know that was going on, or whatever. Or you made me feel better that I thought this was going on and this isn't going on. All those things. There's no better compliment than whenever someone tells me that they had the most thorough evaluation they've ever had. It's kind of like they leave, and whenever you're alone in your own clinic, you kind of like celebrate a little bit. Like you're in your private space, you feel good because that's why I'm doing what I'm doing. Is because I want the patients to feel like they were 60 minutes, sometimes more, because I do talk a lot, 60 minutes of this uninterrupted attention time to them and their specific worries.
Do you think that because you are a cash-based provider and you don't follow the insurance model, that they get a more thorough evaluation? Because
I don't know if this is accurate, but I've heard that if you are going through the insurance route and you have a wrist injury, all they can do is focus on your wrist. That's all that the insurance will cover.
Okay, so I can definitely speak on that from my own experiences because I haven't been an out-of-network clinic or an out-of-network provider for my entire career. So I can pull from a lot of my own experiences and what, albeit great individuals, I definitely had quotas and I had supervisors telling me, what I needed to focus on, time, effort, energy, and it all goes back to reimbursement. That's what it all goes back to. So let's just say that you said wrist, left wrist. Okay. So we'll even back up a little bit. So I used to take pride. It sounds funny to say this now, that I would have 3, 4, 5, 6 patients at one time. And I actually looked at that at the time of my life as that made me a better PT because I could handle 6 people at one time. Like I had convinced myself that the more patients I could juggle and they didn't know that I was juggling. I even had like little expressions about it, like the busier you think I am or that you don't think I'm as busy when I'm really busy, all these things that I thought it made me a better PT. And I used to say like, how, when you only have one patient at a time, how are you filling your time? Like, what are you possibly doing, right? In retrospect and in hindsight, always being 2020, I was in that insurance model. I was doing a new patient evaluation with 3 patients out in the gym waiting for me at the exact same time. And if the referral said, M25, blah, 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 just wrist pain, then that's all I was in there to do. Let's look at the wrist, what's going on. Sure, we're going to take our time in the moment, do some movement-based testing, do some joint work, what's weak, what's not weak. Some of this, I hate to say bottom of the barrel or like quick measurements, and it paints a picture. It's just not a very precise picture. And it might paint the outer layer of the onion, but it doesn't get to the deeper layers of like why, what, when, where, how, all these other questions that in the world of out-of-network physical therapy where you're not hindered by the barriers or the restrictions of insurance, I now can afford the opportunity to spend that time with my patients and try my best. The evaluation never stops, right? Like even the second session, the third session, you're always evaluating, you're always reevaluating. But I can take the time to make sure that I have crossed every T, dotted every I, dotted every lowercase j, the whole thing to make sure that I didn't miss anything. And I'm comfortable with not missing something, right? And sometimes I remember speaking for myself in the old ways I used to do it and still out there, the insurance-based physical therapy, which these therapists are doing their best. They're probably gassed out by the end of the day. I wonder how many things I might have, like little things that I might have missed that took a patient getting better in 6 visits in the insurance model that I saw them for 24 visits because it just took me longer to get there because I didn't have as much one-on-one time with that patient and I wasn't able to treat that person in front of me. There's a shoulder in room 1, there's a knee in room 2, that, it's just very fast paced. And yeah, at that time, it's crazy to think about the position where I thought that was what I was supposed to be doing. I thought seeing 40 patients a day was impressive. And in hindsight, it's not impressive. I'd rather see 5 patients, and I come home more tired than ever now with 5 patients. And if 10 years ago, a version of myself would hear me say that, he would probably say that, what do you think? 5 patients, that's easy. Not whenever you're putting everything in that moment with your patient and you're being present with your patients. It makes to me, it makes a big difference in the quality of care. And the results speak for themselves that I've witnessed them, that in one visit I can do what it took me 3 weeks in the previous model.
So are you the only physical therapist under Flow Physical Therapy?
So of course it's me and Dr. Melissa.
Yeah. Are y'all both under the same umbrella, the same
Yeah,
practice?
so
Okay.
Flow PT and Louisiana Pelvic Health. So I'll do a quick little background on where this all came from. So we were Louisiana Pelvic Health first in Houma, was the original iterations of our clinic. And then we got Hurricane Ida a little bit, kind of messed us up. And we temporarily saw some patients in Broussard. We got welcomed in by a clinic. We saw some patients in Broussard to give our Houma patients an outlet if they needed to come see us there, because while we were down and out, but also introduced us to this Acadiana region, which we fell in love with. So after Ida, The plan, which life changes, the plan was to come straight to Acadiana, whether it be Lafayette. We didn't really know yet. But then life took us to Texas temporarily for a couple of years. And Louisiana Pelvic Health doesn't have a good ring to it in Texas. So I made a list of potential clinic names. I think I had like 300 clinic names on here. And FAAOMPT was not on that list. I was at like lunch by myself, and we had just talked about like movement flow or yoga flow or something along those lines. I forget. And I was like, FAAOMPT. I don't know. I was like, what does it mean? And I was like, function, lifestyle, orthopedics and wellness, movement flow. I was like, okay, I'm orthopedic. That works for me. And then Dr. Melissa, I was like, what does it mean for her? I was like, well, fertility, lifestyle, orthopedics and wellness, and then, menstrual cycle flow, movement flow, yoga flow. It all kind of came together as we became FAAOMPT in Texas. So then whenever we finally were able to move back to Louisiana, she wanted her baby back. She wanted LPH, Louisiana Pelvic Health. So we have Louisiana Pelvic Health and FAAOMPT.
Gotcha.
But we're under the same building. We are right there side by side, always the gruesome twosome. Same phone number, just me and her. It's, like the old Saturday Night Live skit. We wear all the hats.
Yeah.
We do all the unlocking the door, locking the door, answering the phone.
Yeah.
Website design, the whole thing. It's just
got to be
us
fun
two.
to work with your spouse too, because it's like your business partners. You can use each other as a sounding board, and it's like you're doing everything together.
It is. It's
100% certain that I could not work with my spouse. 100%.
I think for us, it has turned into a very positive experience, without a doubt. There's no other avenue I could see myself working in right now other than alongside Melissa. But with that being said, it does take a little bit of like awareness of like, we're not at work right now, or, some barriers, some boundaries. We are both physical therapists. So like we have to talk about things other than physical therapy sometimes. And that's really hard for two people who love physical therapy.
Two nerds.
Exactly. Because I'll come home and she'll be just like reading research. And I'm like, okay, that's cool. And she's like, look what I found out today. Like, this is all we do.
Yeah.
So it's almost more of a challenge for like, hey, let's go to the park today. Let's go to the splash pad. Let's not think about it. And then all of a sudden I'm like, that guy looks like he's got a limp over there, but really it has been an unbelievable experience, and it will continue to be an unbelievable experience. Working alongside my best friend all day, every day. It's like, there's no better coworker for me than being right there, one room over from my wife. Yeah.
And just to be clear, me and my husband have a wonderful relationship, but it's because we're not together 24/7.
Sure, it's testing. I mean, have we never come home and complained about a coworker? It's like, I can't do that. I'm coming home and talking to my coworker. So there's always two sides to the coin. But when I really think about it, or like there's no other work setup I'd rather be than right next to her.
That's awesome.
Do y'all work on each other?
So that's funny. No, not particularly. Now I'll tell you why. And it's kind of like, does the chef come home and like want to make like a 5-course meal? Like, sure, we try to do the best we can to like offer PT advice if someone has like the quintessential, like my neck hurts or like whatever's going on, like aches and pains. I probably could be better at that if I had to sit here and rate myself as being a home PT. But I think it's, we do believe in our profession. So, I refer out to other PTs sometimes. If she needs some PT, I might give her my advice and my tips.
Yeah, sometimes I don't want advice from my husband, even when he's right. Like,
it's just.
I'm gonna call Daphne.
And I have told her this, and we have done this, where if I need to work on her, if like something's bothering her, whatever that could be, we're gonna do it at the clinic. Like, come to the clinic and let me get like in my headspace, because it's not gonna do you any good if I'm like watching a program on TV while I'm trying to work on your neck. Like, I want to make sure that I do it correctly, and same would go for her. So yeah, we do, but not as much as you would possibly think. That's a common question though. That's not as much as you would think though.
So you started with athletes. What is your bread and butter now?
I find myself over the years, I've kind of like accidentally carved out the population that it's turned into. And what that population has kind of turned into, it's helping people who are frustrated with the traditional system, that have tried traditional PT. They've tried the like endless amount of like session-based, insurance-based treatments. They're like recurrent pain, chronic pain. They're they're starting to go down I don't want to say like the negative downward spiral, but like they don't trust their bodies anymore. They're waiting for themselves to have a flare up again. So they're always like on eggshells, and they're losing confidence in their body. But there's typically with my patient population, they already have some form of an active lifestyle. That doesn't mean that we can't work with if you're not active, but busy professionals who don't have 3 days a week to go to PT clinics. I always tell people I'm the only nerd that wants to go to PT 5 days a week, and I'm the only one that wants to be PT forever. So my patients have over the years started to morph into the busy professional who maybe needs a more time efficient approach where they come into the clinic once a week, sometimes less than that. Before we deliver, our programs to them, we stay with them between sessions, the whole thing. So yeah, busy professionals, active individuals, weekend warriors, maybe someone that doesn't do much Monday to Thursday, then they have a softball tournament on the weekend, and then they have an ache and a pain, or my gym goers that are 80% there, but there's something that's keeping them from getting over the hump of feeling 100% or being able to hit their max, things like that. Those patients that have come in, I found myself kind of treating that demographic a lot over the past couple of years. That age where you start to reinvest into your health. You don't think about it when you're 20 because we're invincible. It starts to creep into your mind. Mid-30s, the whole thing. 40s, 50s, 60s. There's a shift, and everybody's different. Everyone has that realization at a different moment where, you know what, this is the one body I have that I need to make sure that I get the most out of it. And the more that I can address it on the front end before things become a larger problem, then the easier it is to address. It's like getting your oil changed in your car.
Yeah.
If you just never get it done, you're going to have a major issue in 20 years. But I think my demographic is young adults, young professionals, busy individuals, weekend warriors with chronic pain, recurrent injuries that need a different approach because the traditional healthcare system, in my opinion, has probably failed them in the past because it offered quick fixes only. They want an actual solution, and they want someone to spend the time with them to uncover the 2 layers deep of why that thing keeps coming back, whatever that thing is.
I think that's the common theme with not just PT, but all healthcare in general. People are starting to demand more from the providers.
You should. It's because there was I think the tide's kind of turning a little bit where like for so long, there's been a little bit of this hierarchy. And I'm not saying recently, but it's like historically where the white coat kind of pedestal talking down to patients. Patients are expected, or were expected, I should say, to just like take it at face value, take whatever medicine, do this, do that, follow the instructions, without any like autonomy.
I used to work in the VA system, and it was very much like that. The patient did what the doctor was told, didn't ask many questions, and that was it. The doctor was the leader, the head honcho, and you just do what they say.
Exactly. And speaking like my mom, for example, it's like, what is this medicine for? I don't know. They told me to take it. I have to take this in the morning. So it's like, I think we've come to a point where more and more people are kind of opening their eyes. Seems dramatic, but they want to accept more onus onto their own healthcare. They want a little more patient autonomy. They want to be a part of their own decision making for their own, whatever their situation is, whether it's in my world, whether it's a chronic ache, an injury, recurrent pain, whatever the case is. But there is, I think, more emphasis on the patient going direct to a PT, taking care of this and not waiting months and months and months for unnecessary imaging, unnecessary medications, unnecessary injections, unnecessary surgeries, which I've seen multiple times, just because they went through a process where they were checking boxes to go through a system that really didn't have their best interests in mind. And I think it's changing where people are like, you know what, I could probably handle that in 1 month's time and have a plan to not deal with this ever again.
Yeah, just be in the driver's seat of your own health.
We should be.
Do you have to see people in person?
I prefer to be in person, especially on the front end, because a lot of my assessment, a lot of my, I guess, skill set is going to be hands-on. Let's feel the movement. Let's see what's going on with the joint. What hurts, what doesn't hurt, etc. And then a lot of my treatment approaches, yes, there is a hands-on component to that. With that being said, there are a lot of patients that I've had over the years and still today that the missing link is a guided corrective exercise program that isn't just like throwing darts at a dartboard or pasta on the wall to see what sticks. It's based specifically on like a movement analysis that you can do virtually, and then we can guide you through. But the way that I feel about physical therapy and the way that I address my patient care is that I think that the gold standard on the front end is at least to come into the clinic. So let's work together so we can get our strong baseline. And then a lot of patients, depending on their situation, because everyone is totally different, might come in once a month or once less than that, maybe. I'm not sure. Everybody's different. But then in between those sessions, it's like, what are you supposed to do?
Yeah.
With no guidance, nothing's really going to happen. But if you have daily guidance from your therapist who's got your best interest in their mind, then you can still make progress without needing to come into the session 3 times a week, or in my case, 1 time a week.
Well, so the other question is, you've kind of alluded to the multiple sessions of working with a traditional physical therapist. Do you have like an average number of sessions that, I know that's a very loaded question because there's so many different things, but like an average number of sessions that you would normally work with someone?
Yeah. So traditional PT, insurance-based PT, I have witnessed, I've done chart reviews where these patients are getting up to 30, 40, 50 sessions 3 times a week for months and months and months, thinking that it's covered by insurance, and then they get a surprise bill months and months and months for $50 sessions worth of co-insurances, etc. Not a good situation. In my clinic, in my world, the way that I'm currently providing physical therapy, I break it up into phases, if that makes sense. And if you're coming in like phase 1, let's get out of pain. Let's uncover the root. Let's see what's going on, and let's get out of pain. That's whenever my patients typically are a little more hands-on heavy. So like coming into the clinic once a week, we're going to make leaps and bounds progression, whether it's with mobilizations, manipulations, cupping, scraping, dry needling, all like the features and whatnot. Painting with a broad brush here, maybe a month or so, plus or minus, if you're coming in weekly. And then we start, maybe move on to phase 2, where it's more biomechanical and certain strength training heavy, where we can start to phase out of the clinic, where you might come in once a month or twice a month, and then we stay touch point in between our sessions. So the way I look at it, I don't like to put too much emphasis on like how many sessions does it take to get better. I like to put the emphasis on like the process and how long does it take to get better. Like the journey isn't about just the pain, because the journey never stops at the pain. It's always, what is the pain keeping you from doing, and where do you want to be if you didn't have to worry about pain? Where do you want to be if you weren't constantly perseverating on, will I hurt tomorrow if I do this today? And if we stop at the pain, then we're always, like I mentioned earlier, we're always a victim to our pain. We're always responding to a symptom in our body, and we're always being reactive. So I try to change the emphasis to, after we get out of that pain, that's in our rearview mirror, now we have work that we can do to keep it in the rearview mirror. And sometimes I feel like that's the missing link, because in the insurance model, the second that I would get someone out of pain and then like I grade them a 5 out of 5 on a muscle scale, like that's what insurance wants to see, they're going to say, all right, you're done. That patient no longer needs therapy. And right.
Then they don't cover it anymore.
Exactly. So in my mind, in my world, the therapy isn't over at that point, because I'm going to see that. I can almost guarantee at that time of my life, I was going to see them again in 6 months for the same thing or something similar. So what are we doing? You're dumping money into the quick fix or into the temporary relief, whenever the journey is the journey, and the journey can be different for everybody.
God, I'm thinking about just so many situations where like a family member's missing out on a holiday because they can't get in the car and drive or even fly. It's just like so difficult to get anywhere, and it's such a deeper, more emotional consequence of this pain.
I remember specifically this one patient, which for some reason in my mind, I can like think back to almost like, I feel like every patient, like thousands of patients, I like hear their stories. It's such a side benefit of being a physical therapist, is like connecting with people and like having the opportunity to hear their stories. But this one particular patient, all she wanted to do was cut onions for Thanksgiving. That's like all she was thinking about doing. She didn't care that her shoulder hurt. Like she really didn't, but all she was stressed about was cutting onions and picking up her pot. And that's just one of many cases. I've had multiple that just wanted to get on a knee to propose, like that kind of stuff. Like all this is more than pain. And for, I get why, but the conversation always tends to kind of come back to pain, like get out of pain. But it's more than that. It's what is the pain keeping you from doing? And that's where I've kind of landed. That's where the old feather has nestled down, and where I get the most joy is her coming in telling me that she cut her onions. And I'm like, all right, that's exciting. Like, that makes me super excited that you felt comfortable to cut your onions without, and maybe you were thinking about the pain. That's okay. Like, we can work with that, but you were able to do it. Darn it. Like, you did it, and we did it together. And now what's next? And we're going to keep going. And it's kind of maybe over a little bit dramatic about it, but it's like, I just feel like being a small piece of the puzzle in that person's life and giving them that freedom of going on adventures and the confidence to move and picking up their kiddos or giving their kid a bath or something like.
Because in their mind, cutting onions is more than just cutting onions.
Sure.
It means so much more.
Cooking for your
to-
family.
Yeah. Small things are the big things. The
Yeah.
second you can't do small things, that's when people usually say, it's time for therapy. It's not the big things. I can't go rock climbing. No, I guess I'll just miss going rock
Yeah.
climbing. But you suddenly can't do these little things, then people realize that's the problem, and we need to address that.
Yeah, we talk about this a lot, the longevity. It's not necessarily how long you can live. It's how long you can live a good quality life and just function well.
Absolutely. What is life without like smiling and memories and experiences? And it's tough to have experiences when you're always thinking about what's holding you back, especially whenever what's holding you back is something that is very much addressable. When you just find a provider that has taken the time to just like, let's address it. We can work together, and I can help assist you and guide you to where you need to be. If we go to this journey together. The fellowship. What the heck is a fellow? What is the fellowship program? And whenever I tell people I went through a fellowship, like, I'm not a priest, people always ask that. Like, so I'll back up. As I mentioned earlier, like, I had a goal coming out of PT school that I wasn't just going to be a generalist PT. I wanted to become board certified in orthopedics. I was able to make that happen, and I told myself at that moment, I'll never forget, because I was sitting down at the table at the jeweler, getting the engagement ring for Melissa whenever I got the results for my test that came in, and I was an OCS. I can put myself in that exact moment. And I told myself, all right, life's good. I'm never taking a test again. I got my credentialing that I've always wanted to do, and I'm about to get married. This is great. And it was. For a little while, I was like, all right, I'm an OCS now, which is a credential for the board certification in orthopedics. And then a couple of years later, it's like, no matter what profession you're in, it is so easy to fall into a rut if you let yourself accidentally. If you don't challenge yourself, if there's nothing in front of you that you're aspiring to be or to be better, then it's easy to accept the status quo as norm and to not move forward. And in the world of healthcare, as we all know, like, if you're not moving forward, you're getting left behind. So the OCS credentialing, I rode that high for a little while. And then I kind of nestled back down into what's next. This can't be it. There's got to be more out there. I'm still not getting people as efficiently better as quickly as I want to. And the 7-letter itch is the fellowship credentialing, FAAOMPT, I call them, FAAOMPT. And it's the credential that I've held in the highest regard since I came out of PT school.
What does that stand for?
You are a fellow of the American Academy of Orthopedic Manual Physical Therapists. Okay. And in the reality of credentialing in healthcare, and I say this a little bit tongue-in-cheek, but also there's always some truth to it. There's a lot of credentials that mean nothing. And there's nothing wrong with that. I've had more credentials that I've had so many of them that, like, I don't know what they stand for anymore, or like I haven't used them in decades, or not decades, but years. Yeah. And not every credential carries weight. And whenever I came out of PT school and I started understanding what a fellow was and the process of going through a fellowship, immediately I started to realize why all the research papers, all the leaders of our profession, all shared that credential of the FAAOMPT, of the fellow. And I kind of legitimately say this, they don't give that credential away at all. It takes years to get that credentialing.
So, yeah, what is it?
So you have to go through an accredited program that offers that credential, and then you have to be awarded the credentialing upon completion of that program. I went through the American Academy of Manipulative Therapy, where I consider the front runners of dry needling and spinal manipulation within the physical therapy profession. And it took me, that program's a little beyond 2 years, right at 2 years. And I completed that program a few years ago. where it's beyond just taking coursework, see you later. It's testing, is rigorous testing with your instructors, peer-to-peer testing. One of the tests was like a 8-hour test. It was an 8-hour test from 8 a.m. to 5 p.m. where it was the written portion, then the hands-on portion, and then the verbal portion of it. So it's a very in-depth process to get there. It's right there in the name. So the fellow of the American Academy of Orthopedic Manual Physical Therapists. So orthopedic is going to be the PTs that are even interested in this credential. So like if someone's expertise or their career path is neuro-based or pediatric-based, they're probably not overly interested in getting the fellowship. And the manual physical therapy is just like our way of saying hands-on. So hands-on being what the physical therapists call manipulations or grade 5 mobilizations, what chiropractors call adjustments, kind of an overlap of skill set there. So fellows have, and then biomechanically, the joint work, like moving the joint just a smidge this way or a smidge that way, it makes a large difference. The way that I feel about the fellows is that the fellowship credentialing in the world of orthopedic physical therapists, there's only lateral moves. And there's not really, to me, there is no lateral move. But if you wanted to discuss it, there's only lateral moves. There's nothing, to me, the way I feel about it, that's above that. So if someone comes and chats with me that they have a fellow, my first question is, who'd you get it from? And I say that because every school maybe has a different, they lean into different things, or they're heavier on different topics, if you will, or approaches. So I like to bounce ideas back and forth. Usually these are the big nerds that can like recite research and talk about like, or even participate in research. You know, my clinic, we did, the paper isn't out yet, but we were part of a multi-system randomized control trial for dry needling for mid-portional Achilles tendinopathy a couple of years ago. We got to treat our patients under the scope of the research article. So we're just the nerdiest of the nerd, where whenever we're typically going to look at the person a little bit differently. And I felt the transformation. It's like going to boot camp. I was 10 years in as a PT going to a fellowship program, and they stripped me down on day one and it made me feel like I didn't know how to move a joint or like stretch someone's hamstring. Like they just make you completely ground level again and rebuild you back up. And then you come out of it on the other end after all these great mentors. You come out of it on the other end just with a new way of seeing movement, and a new way of seeing the patient in front of you. You know, general treatment, I tell patients, general treatments don't address specific problems. When you're a fellow, you don't do general treatments anymore. There's no more cookie cutter. It is, we're doing specific, everything we do has a reason. And when you go through the fellowship, it's like going through being taught by a bunch of third graders, because no matter what you say your treatment is, they're like, why? And they never stop with the why. And you better not have an answer. You have to know why you're doing. It's no time fillers. So everything has a reason. So I hold that in highest regard. Through the American Academy of Manipulative Therapy en route to the fellowship, that program, you can be awarded the diploma in Osteopractic physical therapy, so I'm considered an Osteopractor, which is pretty much a subspecialty of physical therapists. The way that we kind of describe it is, if you have a heart condition, you're going to go to a cardiologist. If you have a bone, joint, tendon, ligament, you go to a physical therapist. But even beyond that, you can go into the world of an osteopractic, which is more of an approach than anything, where you earn an osteopractic diploma after you complete, I think it's 18-ish months or 18 months of coursework with the actual testing at the end of each part of the curriculum. So through there, you can get certified. Through the process of becoming an osteopractor, you get certified in vestibular rehab, you get certified in dry needling, you get certified in spinal manipulation. Now that we're getting big into the ultrasound guided dry needling, BFR, like this whole world, it's a good way to show that you didn't just take a weekend course on it. You took the weekend course and then you stacked and you stacked and you stacked, and you were held accountable for what you learned at the weekend course, which I've taken many a weekend course in my life. No one's there on Monday to hold you accountable for what you just learned on Saturday, Sunday. It's up to the therapist or the professional at that point to implement what they learned. And when you go through a regimented program, you're held accountable to like speak on it and speak on it and speak on it, and then practice it and show it and prove it, and video it and all these things, to keep you hopefully moving forward and really driving you as a professional, driving you crazy sometimes, but driving you as a professional to never settle for not good enough.
Do you work with orthopedic surgeons?
In what way?
Referral.
Yeah. So, yeah, yes and no. Here in Lafayette, I haven't dove too much into the world of orthopedic surgery. The reason I say that is because if they've already gone that route into the orthopedic surgeon's world, a lot of times I don't catch them. Like that patient's already kind of got their mind that they've gone through that traditional route of needing surgery, which is definitely appropriate for a lot of patients. If you come in for me direct access with shoulder pain and I suspect, okay, we have a significant tear here, a full thickness or something that needs further workup from an ortho, then yes, definitely can refer to an ortho surgeon or an orthopedic for sure. But I refer to them to make sure we're on the same page. If they need the surgery or not, they of course do their own assessment, they do their images and all that. Because they definitely have their own algorithm, right? Like I always say this, like a surgeon, they're a surgeon because they perform surgery. I'm a PT because at the crux of it all, like I borderline try to get people to avoid surgery if possible. And then if they have undergone a surgery, then let's maximize the surgery.
So you don't work off of images at all?
No, and I'll tell you why. There's a time and a place for imaging. I'm thinking in my head X-ray specifically, but kind of MRI falls into this as well. But here are the two things that happen after an image. And let's say X-ray the low back, okay? One, that patient's going to come in and they're going to say, they said my X-ray was fine. Like nothing's wrong. Instant stress, instant, well, what's going on? It feeds into almost like a panic, if you will. Yes. The opposite can happen. They come in and they have a lot of things going on, but the patient is potentially fine in front of me. A couple things can happen there. One, they're incidental findings. That's not even a pain generator. So the way that I feel about imaging is this, is that if you bring me your image, MRI, X-ray, whatever the case is, on day one for the evaluation, I gladly take it. I put it face down on my desk and I do my assessment without looking at it because I don't want to be skewed, biased, or pulled towards any direction because at the end of the day, the patient is the patient and you're in front of me and you're going to tell me more than that image is going to show me because that doesn't always line up. It is a one-dimensional photo or, not to mention, is it loaded? Is it not loaded? There's just a lot of shortcomings. And sometimes we can put too much emphasis on an image. With that being said, they are important at times. And if we feel the need, then we can. I do think imaging is a massive part of inflated insurance costs because of the overutilization of of imaging studies. And if you had to best the major reason of the most of low back images or X-rays, it's really cover your butt X-rays where they just send people in for X-rays to make sure they didn't miss anything. But there are algorithms like Ottawa cervical rules, Ottawa ankle rules. Like there's algorithms that we can walk through of is an image even necessary? And if you follow those algorithms, most of the time you're safe, you're fine. But so yeah, you don't need an image and I don't follow it. Or I'll look at it afterwards. And usually it lines up with what we talked about.
Before we let you go, we always ask our guests one last question.
Uh-oh, here we go.
Final question is, what does living vividly mean to you?
I think living vividly could be, sometimes we live in black and white, sometimes we live in gray. I think whenever you expand your mind and you look at the whole world in front of you, you live in color. And the more that you live in color and you see everything in front of you, then the better that we can serve our patients and really our immediate circle around us with open eyes and take our friends and family in and have more to give and offer our friends, family, and patients.
Thanks for listening to Living Vividly. If you enjoyed today's episode, please leave us a review and subscribe. We'd love to hear from you. For more resources and details from today's discussion, check out the show notes. Until next time, keep living vividly.